Okay, let's talk about how to work up the patient with glomerulonephritis or someone you suspect may have glomerulonephritis. And so I like to say that obviously step one, make sure you did a urinalysis and at least looked at the urine microscopy just to make sure that GN is on the differential, that it seems like a possibility. My main point in emphasizing this is that you don't want to order a series of expensive tests if there's another more likely cause for the acute kidney injury or the disturbance, okay? So remember, if GN is on the list as a clear possibility here, then it's worth ordering the expensive tests. So I think this serves as a good first pass for the labs you would order when you're considering a patient may have GN. And so remember, lupus nephritis is always a possibility, so you can order the ANA screen and an anti-double-stranded DNA test. A lot of our diseases can be associated with reduced serum complements, especially C3. So you want to check serum complements. Then Anca screen is important because if they're circulating Anca, we could pick it up here. Anti Gbm disease is a disease that can cause RPGN, and you don't want to miss it. So you can go ahead and order the Anti Gbm antibody. Remember, some of our diseases can be brought on by chronic Hep B, chronic Hep C, or even HIV. And so if a patient has not had those tested recently, you at least want to check that because you could make the new diagnosis of some chronic infection. And then remember also we have to consider TMA or thrombotic microangiopathy, so checking hemolysis labs. So looking at the CBC for a new anemia, looking for new thrombocytopenia, and then also signs of intravascular hemolysis. So schistocytes on the blood film, elevated LDH, so signs of red blood cell lysis, and then also a reduced haptoglobin would be a sign of free intravascular hemoglobin, which would be bound by the haptoglobin, and this entity would decrease. So as part of this workup, let's say that the patient has a positive ANA and a positive double-stranded DNA. This would strongly support lupus nephritis, and obviously you're going to go back to the patient and screen them for other signs and symptoms of that disease. Also, some diseases that cause a GN are associated with low complements, and so this includes the infection-related GNs, MPGN, atypical HUS, the C3GN, and also cryoglobulonemic GN, and of course lupus nephritis. So what if you saw low complements? I want you to consider these diseases as well as lupus. So next, if the patient has a positive Anca screen, I want you to at least consider then ordering the more specific antibody test. So the anti-myeloperoxidase antibody and the anti-proteinase 3 antibody are more specific for the Ancas. And so the Anca screen, if it's positive, you can order then the more specific test. And then also remember, some of the diseases involve the lungs, and so it's probably worth doing some sort of imaging of the lung or going back to the patient and screening them for sinus symptoms, upper respiratory tract symptoms, looking at their skin for rash, just because, remember, all the diseases can affect organs outside the kidney. And so you'd want to screen the patient for extra renal involvement. So next, if the Anti Gbm antibody is positive, I think that would strongly support GBM disease being present, or Anti Gbm disease rather. And actually, if that were the case, you may actually be also interested in getting at least a chest X-ray or CT chest, because if there's involvement of the glomerular basement membrane, but also the lungs, that's when we call it Goodpasture syndrome, and the management is a little more aggressive if there's pulmonary and renal involvement. So anti-GBM antibodies plus some lung involvement, especially alveolar hemorrhage, would be really important to diagnose early. Next, so let's say our hemolysis screen was positive. So if you've identified hemolysis, these are the next set of labs you should at least consider ordering. So if a patient has TTP, they're going to have abnormal Adams TS13 activity. So you can order this assay that can measure the activity and the presence of the enzyme. And then also, if your patient's having a diarrheal illness and you suspect an infection, you should get a stool culture, because that could explain why the patient's having hemolytic uremic syndrome. But what if they're not having a diarrheal illness, and it seems like the hemolytic uremic syndrome is sort of happening sporadically or in response to some minor insult? Well, in that case, you can order the atypical HUS assay, as well as a genetic panel to screen for genetic mutations. Also, if a patient maybe has a history of lupus, you could screen this patient for antiphospholipid antibodies, because that could also cause a thrombotic microangiopathy. So based on the first pass of labs, this is how I sort of interpret the follow-up, and then you would move on to more specific testing based on what came back first. The idea here is to sort of have a cost-conscious approach to how you order these, because some of these labs are really expensive, and also if you order something, you want to make sure you know what to do with the result first. And of course, the most important diagnostic test is the kidney biopsy, because we get so much information from that, and I hope the videos on the mechanisms of GN has been helpful in making that argument, because we really rely on the pathology as well as the immune fluorescence staining to help us understand what's going on in the kidney and what's causing the disease. So the serologies really just give us clues as to what's happening, and in many cases we can't really use the serologies to help us with our understanding of what's happening in the kidney, and in those cases we have to get the kidney biopsy. Sometimes even if we know what the diagnosis is, let's say if it's a clear case of lupus or a clear case of Anca vasculitis, it's still important to get the biopsy because it helps us understand if there's underlying scarring or chronic damage, maybe the acuity of the problem, and how much is reversible through immune suppression therapy. So most of these patients are going to end up getting kidney biopsies because we get the most information that way.